Let's start with me. Who am I? I've been working in health technology for almost 15 years across Australia, Canada, the US, and I currently head up product at Midnight Health. In that time, technology has changed significantly, and the application of that technology into healthcare has now taken a life force of its own. Technology available to those inside the health system and to patients today was science fiction when I first started working on health projects, and I can't wait to see where we are in 15 years from now. I've worked on systems both in and out of the hospital system, from patient administration systems, oncology, medication management, aged care, and primary care. Earlier in my career, technology systems in healthcare were seen as a burden or a way to document an episode of care. Very static, uncoded, unreadable information. And the last point, I've been accused of always living 2 years in the future. As a forward-looking product manager, I'm working on solutions now that won't be delivered for 2 years. This has its positives and its negatives, with negatives being once a solution's been designed and passes on to development, that idea now exists in your mind and you move on. You start thinking about the next thing. The positive, however, is being able to think about how that technology can assist the users of the healthcare system, that is, clinicians, carers, and the patients themselves. Let's get started by looking at the differences between machine learning and analytics. Analytics is a way of presenting data to a consumer, often through graphical visualization, like dashboards and graphs and the like. The data may come from multiple disparate sources that would otherwise take a lot of time to collate into something useful. These graphical visualizations are designed to promote data-driven decision-making by providing the insights into trends, patterns, and outliers, with humans being the ones interpreting what they're being presented with. Analytics are used currently in healthcare across many uses. In primary care, dashboards are used to track KPIs and practice performance, primarily financial, with some applications to population health, extracting to PHNs and the like. Hospitals utilize analytics in multiple settings, but one example is emergency departments, where dashboards are used to highlight wait times for each triage category, and in each scenario, it's the humans that consume this information. Machine learning allows data to be consumed in a faster, more meaningful way. Using algorithms and models, machine learning can provide automated insights rather than a human figuring it out for themselves. Machine learning models can also change over time as more data is consumed, providing further accurate predictions. In healthcare, machine learning has already been utilized for diagnostic assistance and in radiology. So what do we require in order to leverage analytics and machine learning? To put it simply, we need data and lots of it. We need data on the individual patient, and often we need the whole picture of the patient, not just a subset of their whole record. We need sufficient data on the patient for the algorithms to provide us with a correct outcome. We need the right data at the right time. So what else do we need data for? We need data to be able to build the models that the machine learning algorithms will utilize. This means that we need very large data sets to provide the best model. Otherwise, we get issues primarily around bias that I'll talk about later. Without good data, the models are incorrect, and therefore the systems being built around that model are incorrect. There was a case where chest x-rays could be taken, run through a machine learning algorithm, and the system would provide an accurate detection of coronavirus. This was in early 2019 prior to testing. In a subsequent study, it was found that the clinical use was of little value due to the flaws in the original data. That data was incorrect to start with, and therefore every time they went to try and do a diagnosis through that machine learning, it was actually incorrect. Using analytics and machine learning, how can we use this technology? So I think that we're still a number of years away from the point of patient-centered personalized medicine. I mean, we're starting to get there, but I don't think it's like what you see in the movies, where a machine scans you and knows exactly what is wrong, or you walk into a hospital and the hospital knows why you're there. But I do think that personalized medicine is making a difference right now, and it's making that through behavior modification, identifying patients for clinical trials, and some diagnosis assistance. This has been clearly seen in oncology, where we now know that every person responds to treatment in a different way. So by having a profile on the patient and having algorithmic support, systems can then recommend the best treatment pathway for that specific patient. So personalized medicine has the opportunity to ingest data from multiple inputs and then identify either early interventions, preventing a disease state from taking hold, or recommending the best treatment early to provide better longer-term outcomes. So this data might come from personal devices, pathology results, doctor's notes, building an overall view of that patient. So when a patient's breathing slows, their heart rate increases, or they start exercising less, systems can jump in and jump to action and notify relevant people, that may be the patient themselves, to get help and to say where that help is available. Systems will be able to recommend treatments earlier, so we get better long-term outcomes from patients. Machine learning is also being used to improve those treatments, like drug research, so we get targeted, personalized drugs for each individual patient. Already, we're seeing decision support systems providing assistance to clinicians to treat and identify disease in various settings. Currently, with the technology we're seeing at the moment, the low-hanging fruit is condition identification. That is, being able to identify where a condition may be occurring and to assist the clinician in making the next step forward, identifying what a condition may be. Condition identification is going to be a game changer in primary care, where a general practitioner could start to enter symptoms as part of their consultation note, and then the system will start to help them identify what that condition may be. In saying that, the system could also be recommended the best treatment path, which may include medication and non-medication prescriptions. For example, a fitness prescription delivered through an app to the patient, or behavior modification. A further use of decision support is identifying where a patient is either deteriorating or at risk of deteriorating. A 2020 study found that deterioration of patient could be accurately predicted based on information contained within the hospital EMR, with the warning system having a 257% higher sensitivity than conventional methods used by clinicians in the hospital setting. This shows that as humans, we may not be always aware of everything going on with a patient, and systems are far better at managing this simply due to the amount of information that needs to be processed all at once. Medication interaction checking is already in use across the world. Here in Australia, we already have drug-to-drug, drug-to-allergy, and drug-to-condition interaction checking that's widely used and provided by the medication drug databases. This interaction checking is based off a set of standard rules. However, as analytics and machine learning get better, we'll be able to look at an entire patient record to quickly identify where an adverse medical event may eventuate and to prevent this from occurring earlier. With healthcare comes notes, and notes are often handwritten or typed into a box in EMR. These notes are only really useful to the person who wrote them, as they can be misinterpreted by another person who's reading them, and they may contain unstructured information that can't be used for analysis. New machine learning tools can help turn these freehand notes into data that can be used for analytics and reporting, but also for automated clinical coding, which is useful in a lot of countries for reporting or billing purposes. Other tools can learn how a clinician writes their notes allowing for assisted note writing, saving clinicians time and improving the quality of the note. Tools can also be used to validate the note and to ensure that what's being documented is correct and valid, raising errors to the clinician where the documentation is not right. Another thing it can do is to clean up the note, make it more readable to other clinicians, so that when they're absorbing the information, they're absorbing the same information that the person who was documented the first time wanted it to be explained. Medical imaging has been revolutionized by machine learning and analytics, providing radiologists with additional tools to provide more accurate diagnosis. Some of the cases where machine learning is being used is cardiovascular abnormalities, musculoskeletal injuries, neurological diseases like ALS, thoracic complications like pneumonia and pneumothorax, and then detecting common cancers like breast cancer, colorectal cancer. Medical imaging software is already producing great results in this area and can assist clinicians where a radiologist is currently busy or in countries where they're not readily available. It is also more effective than a human at detecting abnormalities, especially at speed. In most applications, however, the machine learning is not replacing the radiologist, but is a useful tool to assist radiologists or other clinicians, as I was saying, where radiologists aren't readily available. Obviously, if we can analyze a patient's behavior, we can try and prevent diseases from occurring, preventing the need for treatment later on, and this may be much later on in their life. Behavior analysis systems attempt to learn an individual's behavior pattern, where the system can then look to see if the patient is making suboptimal or harmful choices, like eating unhealthy foods, not exercising enough, smoking, drinking too much alcohol. Interventions are then executed for the patient to attempt to prevent those behaviors from occurring, and then trying to prevent the ongoing disease from those behaviors. I'm going to talk about software as a medical device. So software as a medical device is a term provided to software products that act like a medical device. So here in Australia, the TGA approves the use of medical devices, and as such, they've got guidelines on where a software product may be acting as a medical device. In the US, the FDA has very similar guidelines. So obviously, if a product is using machine learning or analytics, we have to decide whether the product is a medical device. So the TGA has provided some guidelines in regards to this, and the following points can be provided as guidance. So we have to look at the product and say, is the software directly calculating and administering medications without clinical intervention? Or is the software making clinical decisions and diagnosis without clinical input? And is it recommending treatments or interventions? If you've answered yes to any of the above, then it's quite likely that the software is acting as a medical device and therefore would be regulated. So this means that it's going to be very difficult longer term to get very fast intervention type products out there, and it's a long process to get approval. So I think that while the software can develop models and do predictive analytics very quickly, getting those to market is going to be quite slow. So if we're to have data in a centralized location in order to provide patient benefits through analytics and machine learning, let's take a look at the history of personal health records. So the first one is Microsoft Health Vault. So Microsoft Health Vault was created in 2007. It was a pioneer in the personal health record space. The record focused on the traditional health record, similar to what you would expect in any type of EMR. And it didn't support patient-acquired data either manually or through personal wearables. One article I found said that Health Vault was next to worthless, as the data collected was primarily used for insurance claims. Wow, that's crazy. So Health Vault provided no insights into a patient's health outcomes, how their health was changing, or ways to improve their health. Ultimately, it was a document storage facility, much like our homegrown My Health record. Google Health came to life in 2008, where Google wanted to create a single patient record that could be used across hospital, primary care, and pharmacy. The idea was that patients could volunteer their records to be stored within Google Health, either manually or by using a partnered health service that had an existing integration. The information that patients could supply included conditions, medications, allergies, and pathology or imaging results. Once the system had sufficient data, it would then start to provide insights on conditions and interaction checking between drugs, conditions, and allergies. Google Health was disbanded in 2012 due to lack of user uptake and the unwillingness of healthcare providers to give consumers control over their health data, something that we see in Australia too. However, the department continued as an internal team, delivering tools and technology to the healthcare industry. As of 2021, Google is once again trying with a product called Care Studio, where the aim is to organize fragmented health information from multiple systems into a single patient view, and then to provide modern tools to make it faster to deliver care. This all sounds too familiar to me though. Does it to you? The Apple Health record has been expanded on progressively since 2018, when Apple announced the Health app to the iOS. Since then, the record now allows for FHIR API access with various providers in the US, where data is consumed but also shared with the permission of the patient. In mid-2021, approximately 700 healthcare organizations and 12,000 care sites offer the option of downloading an Apple Health record. Patients still have to use the hospital or care site patient portal to authenticate themselves, but then they can choose to link the Apple Health record with that organization. So they've got that two-way sharing of information. At this stage, Apple does not appear to have any secondary use of the data and promotes that while the data is stored within Apple, it doesn't actually have access. In order to provide the best patient outcomes from technology, centralized patient records are a must. Ideally, this would be facilitated by governments, but not even here in Australia has this been delivered. Summary of patient data is not enough to provide comprehensive insights on a patient. In order for uptake to be successful, providing data to a centralized repository needs to provide benefits to providers and patients. That might mean that the system can provide health advice to patients while also providing decision support to providers. The entire healthcare system must be connected to the centralized system. In order to have a complete picture of a patient, the data must flow in from every part of their healthcare life, including from wearables and other connected devices like Bluetooth weighing scales and other remote patient monitoring systems. So the data silo is a term used to describe what's currently happening in our healthcare spectrum, where the data is fragmented across multiple parts of the health system, each controlling their own subset of the patient's record overall. Each part of the healthcare system, whether it be hospital, primary care, or allied health, feels that they own that part of the record, and therefore they're often reluctant to share that information. Through conversations I've had, especially with general practitioners, they don't wish to share the information that they have on a patient, as they feel that patients will go to cheaper or free, in the case of bulk billing, clinics for the easy healthcare, and that private general practitioners will be left with the complicated health issues like chronic disease. When data is siloed, there's a huge amount of data that ends up being duplicated, especially patient demographics, family history, and social history. This is information that changes less frequently as other health data, and yet it has to be recorded and stored at every entry point to the healthcare system. This siloed information ends up being stale, that is information that's no longer relevant, out of date, or just plain wrong. When information is centralized or able to be updated from a central repository, it's less likely that this information on the patient will be stale. So let's look at some of the benefits. So patients are the ultimate winners from increased analytics and machine learning in the healthcare setting. Creating patient-led health, where systems support the patient in where to go for treatment or for preventative health. So let's go through a scenario and think about how this scenario could work. So a patient has a centralized patient record. They've signed up with all their healthcare providers, so they're confident that the record is complete. The system runs the patient's data against analytics and algorithms that it has in place. The system then decides that the patient needs to see a cardiologist immediately. The system automatically finds the next availability with a cardiologist, books that appointment with a specialist, provides access to that health record to that specialist, notifies the patient that they'll be speaking with the specialist shortly, facilitates the video conference, then listens to the consultation and automatically generates the next steps for that patient. So if we think about the above, the experience for that patient and the provider is seamless. The healthcare that the patient wasn't even aware of that they required has been provided quickly, and the interventions can be put in place earlier than if the patient had waited until they showed symptoms. The same system could potentially provide targeted treatment, identifying when and what is required for the patient based on the data available. Preventative health through behaviour change and notification of changes in that data is being collected, especially with advancements in wearable technology. So as more data becomes available through these devices, the better the picture we have of that patient. So finally, for the patient, the benefit for them is increased care, as we can start to target the care that they've required, and we can get better care as the clinician's time is freed up. So therefore we get more of it as well. So the benefits to clinicians are obviously similar to patients, but in different ways. A benefit that is often overlooked is the reduction in the administrative burden commonly associated with the clinical environment. So systems can be enacted that predict the required consultation notes. We can automate clinical coding, and as discussed, systems can read those consultation notes and automate tasks. Diagnosis assistance using the data contained within the patient record can be used to guide or recommend different working diagnoses. A clinician that's working with a patient on their health can have systems that assist with the management of that condition through treatment pathways, protocols, or ensuring that the drugs are working for that patient. So by identifying conditions earlier and treating them better, we can reduce the overall burden of the patient on the healthcare system. This, in turn, reduces the costs associated with treating that patient in the healthcare system. There's some other benefits to government that include a reduction in number of investigations that are run, as the systems can start to recommend specific investigations to be performed and when, rather than the shotgun approach used now, and the reduction in clinical time, freeing up clinicians that we have to provide better and more care. The end result of everything above that I've spoken about is a healthier population. So early detection and intervention means longer and healthier lives. Ethics and bias are prominent in healthcare models. I'm going to discuss them both and the impact that they have on analytics and machine learning. Unconscious bias occurs in day-to-day life, and then this is transferred into the algorithms used by machine learning. When a data set only represents one part of a population, that data set inherently has a bias towards just that part of the population. When a machine learning model is then built against that data set, that bias remains. For example, if we were to build a model to predict cardiovascular disease and used data that only contained information from European descended white males who are aged between 40 and 55, then the machine learning model would only work with some accuracy for patients in that group. Those who are outside of that group would not likely get a correct result, or at worst, a wrong result. Bias in datasets can affect both different people of race and sex, as variances occur with both. If data is not cleansed, that is that the data hasn't been corrected of errors that may negatively affect the predictive model. This can include records that don't have a full set of information or data that contains duplicates. Data also needs to come from a large enough sample size that bias is less likely to occur. So if we create a model where we only have 20 people in it, it's going to be less useful to us than a model that has 20,000 or 200,000 records. The World Health Organization has put together a guidance of ethical principles for machine learning systems, with the first one to protect clinical autonomy. That a clinician should maintain the ability to have the final say on health decisions, and that systems should not be able to override a human decision. Machine learning should guide care with the consent of the patient and the clinician and make recommendations, but clinicians can choose to ignore those recommendations. However, there may be legal ramifications for clinicians ignoring machine learning recommendations, especially if that decision to ignore the advice ends up in worse patient outcomes or death. Software developers need to continually test to ensure that machine learning tools deployed continue to work as designed and are not causing harm. The accountability of the tools also needs to sit with the software vendors, as they're the ones who are launching, selling, and continue to develop them. Software vendors need to foster that accountability when something goes wrong. There also needs to be transparency on how that machine learning tool works. It's often seen as a black box, and there is limited understanding on how machine learning works. Clinicians need to have sufficient knowledge on how these systems work in order to not only be able to trust them, but also to know when they may not be working as designed. So I want to finish up with some parting thoughts. So machine learning and analytics are here now, and they're here to stay. As time progresses, we're going to see the systems get better, and there's going to be a lot more of them providing benefits to providers and patients alike. Patient outcomes are going to be achieved at a greater, more rapid scale, even from light decision support and analytical insights into overall health. Even if this is just from rules-based engines. And finally, we should be using data to prevent disease rather than when using the data to always treat disease. As the old saying goes, prevention is better than the cure. Thank you for listening to me today, and I hope that you learned a little bit about machine learning and analytics in healthcare.